again, everybody, and welcome to another episode of The Edge of Healthcare Lessons from Leaders to Use Today. My name is Martin Cody, SVP of Sales and Marketing for Madikit Health, and with me today is Shahid Shah, who is a CEO, founder of a company that I did not know existed until about a month ago. But I think just like me, you're going to want to know what he's doing, how he's doing it. His experience is really par excellence in the area of technology, healthcare, and last but not least, the ever-present AI. Shahid, welcome to the program.
Thank you so much, Martin. It's really, really nice for you to invite me here, and I'm looking forward to having a conversation with both young and old in your audience.
Excellent, because we do have that demographic covered, and especially for some of us older folks, of which I am now firmly entrenched in that category and cohort. I want to get to the AI in a second, but I do want to also talk a little bit about kind of the last 20, 30 years of your career. You're coming to us from Washington, D.C., and you've spent a bit of time in the government, or working for the government, if you will, but kind of walk us through from college, post-college, to what got you into where you are today and why.
Yeah, it's a great little story because I think many of your audience members who often are thinking about, should I get into healthcare, should I not get into healthcare, might find this story useful because I graduated in 1990, computer science degree, regular nerd, propeller head, however you want to think of me, got a really great, almost my dream job at the U.S. Navy. So I was a federal official at the U.S. Navy, so on the civilian side, not on the military side. Mm-hmm. And what I loved about it was just a bunch of R&D shops, right? Things like, doing war games and simulations there, working on code for missiles, and just really exciting stuff that, a kid out of college with a computer science degree would find super useful. What happened at that time is similar to what's going on today in Trump 2.0 administration, which is a little bit of cleanup and reduction in force in government was occurring in the 1995 timeframe. In that case, it was called BRAC, or the Base Realignments and Closures. And so the base that I was working on just up and moved, 200 miles south. And they're like, would you like to come with us? And I was like, I'm in Washington, D.C., a very vibrant city, moving to a farm town. Maybe that's not the best, move for my career. And so when I looked at that, I said, I'm doing something important. I'm doing it with impact. When I go in the morning, when I get home at night, I never feel like, oh my goodness, I wasted my day, because, you're working on tools and technologies for soldiers and sailors, et cetera. So I said, okay, what could I possibly do that might have the same level of impact and still be super heavily involved in IT? What I found was that there was a really cool architecture job at the American Red Cross. The American Red Cross, pretty much everybody knows, has two major divisions. One is their disaster recovery. They show up whenever anything goes wrong. You see the American Red Cross there trying to help out. And then there's another unit that they have, which is for blood collections. Anytime you give blood, it's usually for some purpose, and that purpose is to save someone's life or give them additional help if in their time of need. What was really cool is I just happened to know somebody, got that job like just out of, and this is normally how you would see it, right, Martin? It's not like you have some plan that says, oh, I'm going to go do this big thing, but just basically pure luck at the right place at the right time with the right skills at that time, where they were building at the American Red Cross, we were building out taking individual departments and individual units that are each in each city and creating a unified, fully computerized system at that time in 1995 through about 2002. So that was my entry into healthcare, and it couldn't have been a better entry. We were creating a nationwide system. It was an electronic health record. It was unified. It had hundreds of integrations, thousands of places where there were little shops that were doing blood collection, tens of thousands of users. So it doesn't get more enterprise from an EHR perspective than this. And so when I got out of there, that's what I was a kind of like an EHR expert. And that's how I got into healthcare.
A couple of questions on that. And that's a fascinating story. Where was undergrad? Were you graduated with a computer science degree?
Penn State.
Penn State. Okay. So you're up at Penn State, and then you get a job in DC working for the Navy, which I find fascinating. And then the transition out of the Navy due to I'm not going to move 200 miles south type of thing. And you said you knew someone at the Red Cross. Who was that? You don't have to name names, but how did you know that person?
Well, so I had worked for this particular young lady at the time at another location. She happened to move to the Red Cross and told me, hey, these guys are doing some really important stuff. We could use your skills. So it was one of those things where, like, not knowing anything about healthcare, I would have said, well, I don't know anything about healthcare. What do I
Sure.
do? Instead, one of my rules, leadership lesson number one from this podcast that probably, Martin, you've talked about before is when you're young, you say yes to everything.
Well,
Right?
it's that, and that's kind of where I was going because I was curious where that relationship came from. But I think leadership lesson number 2 or 1.A would also be healthcare is a seemingly massive industry, but it's actually, a microcosm of many, many industries. And the lesson here is don't burn a bridge. You don't know where that person's going to surface and how much you're going to need them later on in life. So all these relationships have tentacles and reach. And if you're helping someone and you're giving value, then they will probably leverage your skills later on. So I totally agree with you on that standpoint with regards to say yes to everything, take every conversation. You don't know where it's going to lead. So congratulations on that. And so that was your entry into the wonderful wide world of electronic medical records and integration and arguably interoperability at that point in time.
That's right. And in addition to that, the world of medical devices, because in this particular environment at the American Red Cross, this was the entire computer system is what we call a class 3 regulated medical device. So it was not under the purview of simple regulations like with the Office of the National Coordinator and others. It was under the purview of the FDA. And it makes sense, right? I mean, if you're taking blood out of somebody's body and then giving it to somebody else, you can literally harm them, if not kill them, if you don't do things right. And that's really the lesson here is when you're doing something super important, you're going to be impacting people's lives. And that's, you have to start thinking about it and say, well, do I want to be on the IT side where I'm working with information about patients? Or do I want to be on the care side, still in technology, but I want to be in medical devices, a pacemaker, some implantable in your brain, an MRI, et cetera. And what you want to think about, from just a career perspective is how much impact do I want? And do I want that, 2 o'clock in the morning phone call where something is so wrong that it's harming patients and you need to get to work? And so when you're young, like I said, you say yes to everything. But I haven't had that particular position for 25 years. I still can remember, like, if a particular phone call rings or a particular pager goes off, it still reminds me of those dozens of times when I did have to go in at 4 o'clock in the morning or 2 o'clock in the morning, because when life matters, there is no time. You don't have, work-life balance and that kind of stuff. You just have emergency world pretty much routinely. So you shouldn't do it for too long. I did it for about 5 years and they were really, really hard. But everything that I know today came from those 5 years of that, almost like a cauldron, as it were. And I'd recommend, unless you really, really love family life balance, do a hard job that matters to a lot of people for a little while so that you can go practice for everything else you're going to do later.
No, I think that's an incredible wisdom. And I like the way you articulated it. Do that very, very hard job, but do it for a short period of time. Otherwise, you'll burn out and then be of very little use to anybody from that standpoint.
Exactly.
So that was early on in your career. And now, within the past 7 days, you've just returned from a pretty robust AI conference in Dubai. And I don't want to minimize everything that you accomplished in the gap between there, but I do want to kind of tie this up in a bow with regards to some of the medical device aspects, where healthcare is going from a digital health perspective, then obviously the explosion and importance of AI, and I would stress the responsible use of AI. So walk us through kind of a little bit about what this conference was about in Dubai. And then part B of that question is compare and contrast it a little bit to kind of AI from an industry perspective in the United States.
Yeah, so this particular conference was one part of what they were referring to as AI Week in Dubai. Dubai's it's a dynamic environment. It's a very small area, so about maybe 4 million people or so, but they're being pretty advanced in fintech, health tech, AI. They're trying to get their tentacles into as many things as they can, drawing people to Dubai, creating it as a financial center, an AI center, et cetera, moving themselves away from oil as their primary source of income into a more diversified environment. And of course, AI is a nice umbrella as well because it hits all the different industries. So this particular event that we were at, there were many different types of people speaking. It was, people from energy, of course, we're in the Middle East. So energy was a big thing. Climate was a big thing. But easily a third of the speakers there, maybe even more than that, were in healthcare-ish technologies, many of them focused on, hey, we don't have enough doctors. What the heck are we going to do? All the way through to, could AI sit on the edge inside the pacemaker and do a better job, right? So you had the entire spectrum, as it were, of
Right.
talks. Now, what was really cool is that there are lots and lots of people that think that AI could do practical day-to-day work, but they're in the United States who are kind of fearful that, if I put this in, who's gonna hurt me from a regulatory, legal, et cetera perspective. And what they've done pretty well in the Middle East in general, even I was both in Riyadh and in Dubai, one thing the government is trying to do there is force people to think outside of the box and say, look, when something goes wrong, it's inevitable. Something is going to go wrong because not everybody knows this, but you're not going to get in trouble for it. And that's the slight difference here, is to say the government telling you, like we used to in the United States. The United States has a fantastic history of trying new things, except we do them in academia, right? That's why you run clinical trials and things like that in academic medical environments. But in general, if you look in normal treatment areas, everybody's afraid, right? We're like, oh, well, I'm not doing that and I'm not doing that. And what they've kind of done really well over there is open the shackles and say, look, yeah, just try everything. Tell us how it goes. Come back to us. And they're funding these. So they're saying, these 3 hospitals try this here. These 2 hospitals try this there. Now, again, it's small. You can't even compare the scale because, with 330 million people, there are 4 million people. But when you take the entirety of the group there are about 70, 75 million people in the entire Gulf Cooperating Council. So it's not like you couldn't do some of those things. And what they have the benefit of is they don't have, 75 years of legacy to try to bring up the case. So what I loved is hearing what the art of the possible was, understanding what is possible in the terms of either ethical AI or reproducible AI, and then bringing that back here is what I really enjoyed. So 2 quick lessons that I learned is everything that is tryable should be tried, right? Except there's the part 2 of the lesson is that the only things that we can't move fast and break things on are those that are literally FDA cleared. Up until that point, like if it's not an FDA cleared requirement, try it out. And even with the FDA, what we found these days, Marty, is that if you look at what the FDA is accelerating with what we call software as a medical device, they're saying, look, even in these areas that are FDA cleared, try stuff out. And that's what I think we're lacking here is we're not as bold as we used to be, 20, 30, 40 years ago, because we're so afraid. We have real tort reform to do in the country. We are afraid for good reasons, but lots of cool things that I saw over there. Yeah.
It's an interesting balance with regards to pushing the envelope, but then also from a safety perspective, not pushing it so far that you bring about harm. And one of the phrases, I like what you just said on those 2 experiences or those 2 outcomes that you're witnessing, but the phrase that you uttered that really caught my attention was ethical AI. And I'm curious, who is determining that?
Yeah, I think the way to think about it is that the ethical AI is generally going to be determined by the person who is going to use that AI. So at the moment, there is no way to quote, teach or train the ethics directly into AI and then not prevent it from doing anything unethical. What you will do though is, so let's look at AI in the same way that we would look at a young medical student who just finished school. They are an intern or a resident somewhere in a hospital. Who teaches them their ethics? And beyond their parents teaching them to be good people, the medical ethics is taught by the medical school, the medical standards, and most importantly, they're training physicians. Correct. And so that's why we have to look at it and say, if I prompt my AI with a bunch of unethical stuff all the time, it is going to give me unethical answers over time.
Yes.
And that's why this problem right now is, I don't think there's a scenario over the next 5 years, let's just say, we won't go too far, is over the next 5 years, we're not going to have scenarios in healthcare where we say it's fully unsupervised, agent-driven, no oversight by humans. That, I think, is a bridge too far at the moment, not because it's technically difficult.
Oh, sure.
It's that there are lots of problems that we can't even fathom that the AI wouldn't be able to handle on its own. So I think if we keep this idea that we are doing supervised AI agents, and the supervision is done the exact same way that medical doctors, nurses, etc., supervise their students, that's a great way to think about how the process should go.
It's interesting because part of me is a little scared with regards to that. And the reason being is history teaches us a lot of lessons. And one of the lessons that I found fascinating, certainly about the investment industry and the stock market as a whole, was when Alan Greenspan was Fed chair. And during the implosion in the 1990s, when the market cratered, he said the single most surprising thing was was the behavior of the CEOs was all self-preservation, not shareholder protection. And so when you juxtapose that to, well, who's going to teach AI, the ethical use of AI? It's going to be kind of the medical institution, the fellow or the training physician, stuff like that. Well, you get a decent OR surgical supervisor pulled to the side and ask him or her, is that doctor pretty good? They'll give you the honest truth type of stuff. So it's a challenge that I think some people are uneasy with as it relates to, well, do we want that person who all of us would agree off the record is not necessarily the most ethical teaching ethics to AI? But it also lends itself to a further question. You gave a talk in 2020 on how investors can sift through AI BS. And I think that was 5 years ago. And now that's very prescient, by the way. Congratulations on that. So teaching the investment community how they can kind of filter through AI from an investment portfolio perspective, and should we invest in this company? I get it. But I also think that same question applies today. Take out investors and how do you teach hospitals? How do you teach payers? How do you teach patients to filter through the AI BS when it comes to adoption of digital health, when it comes to physician selection, when it comes to care modalities and medical devices and stuff like that? Huge question, Shahid. But I think AI is here to stay. And so I want to help health systems understand how to better utilize it, help payer insurance industries how to use it, and not continue to put roadblocks through prior authorization and everything else, preventing the provider from getting paid. And then the consumer, the patient, the member. It is the only industry that all of us will either touch beginning our lives or ending our lives for the most part. It is healthcare. So how do we protect the consumer and leverage AI so that all of it is beneficial to those three entities?
Yeah, I love the framing of that question because it is both complicated, but in an ironic way, simple as well. And so if you treat AI and modern capabilities as an IT project, you've already shot yourself in the foot, because unlike an IT project, which has to be operated by humans, AI in theory could operate on its own, as we just mentioned a few minutes ago.
Great
So
point.
how should you treat it? Treat it more like an incoming human being that you then have to take full responsibility for. Like, it doesn't matter whether a physician is fully credentialed. When they walk into a hospital or health system or a practice, you onboard them with, here's your email, here's your office desk, here's the kind of scribe that you will use. You generally train them even though they are trained. So you say, okay, when you bring in the AI, suppose Shahid's Nuco was created. I've got the most brilliant AI to potentially replace an entire doctor. The way to shoot yourself in the foot is to assume that Shahid's AI Nuco company did a fantastic job of training, and that I don't have to touch that training when it arrives at my organization. That would be like hiring somebody from the outside, a staff aug firm or a new doctor who's just been credentialed, and then say, hey, just figure out how things work around here. No need to talk to me. No need to talk to anybody else. That is almost a recipe for disaster. And you'll see that at the best organizations, onboarding of a new human being is treated seriously, because we know that we have to inculcate them into the culture at Mayo Clinic or UPMC or wherever. And those docs that work at UPMC versus the docs that work at Mayo Clinic, two world-class organizations, by the way, are not interchangeable.
Right.
Why is that? It's just medicine, right? Well, it's because each organization operates under slightly different ethical decision making, slightly different workflows, slightly different everything. And that slight differences is what creates the unique culture of each organization. And so this is leadership lesson for AI. It's very, very easy. Don't treat the thing as a new piece of software. Treat it as if it was another human being, and then figure out what would you do to a human being based on what you are asking that human to do. If they're going to be doing claims reimbursement, what would you do to train them on the claims reimbursement? If they were doing surgeries, how would you train them to do surgeries in your environment? And this is the one thing, as you have, you talk to a lot of leaders, you should ask them about this is, how should we treat incoming software? Well, when it's AI, treat it as a human. When it's not AI, treat it as software because the other humans are handling the work.
That's a profound answer and very valuable. So I appreciate that insight. And it's interesting too, because there's nuance and context there that you talked a little bit about, because if you're treating AI at Mayo, at Hopkins, at the clinic, by the way, none of them are paid sponsors of the program. So if you're treating it as a human, well, yes, it's AI, but AI is going to respond differently in each one of those cultures, each one of those environments, even though it could theoretically be the same AI. So there's that part of the nuance perspective, or shades of gray, if you will, that is completely unique to each other institution, regardless of, it could be Cedars-Sinai, it could be a community hospital in the middle of Kansas, doesn't matter. That culture is different, so the AI is going to respond differently. And so you have to frame it from that aspect, that treat it like a human that you're onboarding. Love that from a standpoint. Now take that, and one of the questions I'm interested in, because we do speak to a lot of experts, a lot of digital health experts in that capacity, is where do hospitals have a blind spot as it relates to AI adoption in their environments?
Yeah, the biggest blind spot is that I've been a CIO and a CTO at a number of different organizations. In the old days, I used to be able to say, I choose the software at the top. I make my selections. I bring them in. I organize them.
You were my arch enemies, Shahid.
That's right. And so in the old days, we were able to do some semblance of control. But this idea of do-it-yourself technology, especially the first time we saw this was with mobile phones. The second time we saw it was consumer-grade SaaS applications that came in. But in the end, if you are a hospital that believes that by telling people that they should not use AI, and that you then believe that you've told them not to use AI, then they won't use AI in your environment, either you're delusional or you're lying to yourself, right? One of the two.
Or both.
Yeah. Either way, it's a problem. And this is an ethical dilemma itself. Here, know, for example, that if I told you, let's say my children, right? We all have kids that we run into this problem with. We ask the kid to know something that they cannot do, and then we blame them for not doing it. That's what we're doing with AI. So you have to assume that people are using AI. It's on their mobile phones. There's apps, etc. You have to train them on how to use it properly in the same way that we would train each other how to be nice to each other, as opposed to having fights with each other. And how do you interact with humans inside your organization? If you go back to that advice of treat it as a human, know that these little minions called AI are running around the hospital. Everybody knows that they're running around the hospital. Every one of them, every person at the hospital has a minion on their shoulder, inside their phone, etc. And they will, unless not given any other alternative, probably use it wrong. There's not a scenario that they're not going to use it, but there will be a scenario that they'll use it wrong. That's how you almost like to treat it. So the blind spot is that you can control the technology from coming into your shop. So what do? Just assume it's already in your shop. Treat everybody like adults. Like, this is one thing I complain to most CIOs, CEOs, board members. I'm sitting in a boardroom. I'm saying, you pay all of this money for these human beings. They're well trained. I mean, doctors are some of the smartest people in the world. Nurses are some of the smartest and most caring people in the world. You bring them in and then you say, don't do this and don't do that and don't do this and don't. Why? It's like, if you are trusting them with the lives of your patients, for God's sakes,
right,
how can you say, I don't trust you with AI? Right? I trust that you won't kill my patients when they come into the hospital, but God forbid you use AI. We don't know what you're going to do. No, that means you're treating them like children. treat people like adults, train them, let them understand what are you afraid of. Now, the other blind spot, though, Martin, is that so one part is they feel they can control the technology. The second part is they think they know how to best use it. Both of them are false. One, you can't control it from coming in. And number two, no one knows what they're doing. Anybody that comes in and tells you that they are an AI expert should then be summarily shot, because that is not a way to operate in a world where like nobody knew this particular kind of technology 5 years ago. Even though I did my AI, I've been talking about it, I'm classically trained in AI, but not in what we have today. Nobody can say that they know this environment. So that second blind spot is, first is the easy one. The second is a little bit harder because they're like, okay, we're going to bring in these experts. Really? Experts in what, right? We don't have any psychologists that know how to operate LLMs yet. Those are the only people that you could bring in to say, here's how LLMs operate. Everybody else, you have to get them to try things, understand that things are going to break, they're going to do some wrong things are going to accidentally happen, and you set up an environment for friendly failure. Not to kill somebody, not to harm somebody, etc. But friendly failure means not everything is going to work out the way you want to. And that second blind spot is easy to cover as well then.
Oh, it's interesting. I like the phrase friendly failure. Understand it. The thing that I also think might be an unintended consequence here is that if there are, in fact, no AI experts, I also agree with you there. And by the way, if you say you're an expert today, you're out of date tomorrow, because that's how fast it's changing. I think there's also a tendency to introduce something that the healthcare industry does not need, and that would be paralysis by analysis. So I see, the leaders that I speak to, there's a consistent theme with regards to what they attribute their success to. A lot of it is risk taking. A lot of it is leaning in and trying things that it's okay to, you talked about friendly failures. It's okay if we don't get the unintended or the intended outcome. What we're going to get regardless is an education.
Exactly.
And then we can iterate upon that education to make a better informed decision in 2 months' time. How does a healthcare organization, an insurance company, a payer, anybody like that, adopt that framework and then make certain that they just aren't analyzing to the cows come home and not actually making decisions?
Yeah, so in those areas, it's similar to the way that they're already familiar with how to make a clinical decision. Like there are things that are very typical. A broken leg doesn't need super long analysis. You gotta do your normal clinical process to fix that problem. But a complex, multi-organ tumor, hell, you got to do an enormous amount of analysis to figure out, well, how are we going to do this? What are the teams going to look like, et cetera? So if you treat every AI problem the same, you're going to have that problem. But again, if you treat the AI as a human or a thing that is adaptable and changeable, and I want to be completely fair to my fellow colleagues at places where we have to make decisions, right? It's a lot easier for us sitting on the outside, not having to live with the consequences of our talking. But as a CIO, if I made a decision, as a CTO, if I made a decision, as a CEO, if I make a decision, I have to live with those consequences. I can actually be fined or in some extreme circumstances go to jail. So putting that aside, it is a culture problem where and this is why I say that healthcare is uniquely positioned to accept AI risks, because we take far, far greater risks with human life. Absolutely. When you walk into a hospital, the chance that you can die of an infection goes up the moment you walk in, right? People know how to handle risk inside a hospital. It's just what we do all day long. Now, if we treat and say, well, AI risk is somehow unique to IT, well, that's why we've shot ourselves in the foot. But if you treat AI as a human and you know how to manage human risk, you hire the wrong nurse, she's going to hurt somebody, right? You hire the wrong PA, he or she might harm somebody. What do? You put process into place. You separate and say, this type of process, this type of outcome needs to have these workflows. The double mastectomy decision is very, very different than a broken leg decision. But if you put everything in the same bucket, you got a problem. And I think that's really the best way, is treat it as the normal risk that you take with humans every day. We in healthcare take risk and manage it all day long. So how do we take the AI risk and patch it in to what we're already doing? That's a great framework for thinking. It's not easy, not trivial by any means,
Sure.
but if you think about it the wrong way, you're going to get the wrong output.
And do you think that ideology at the top in the United States healthcare system is prevalent?
It is in certain environments. So, for example, in academic medical centers, people know what their risks are different than in a suburban clinic, for example.
Mm-hmm.
However, what they don't have is guys like us kind of like elucidating, right? All we're doing is we're kind of like surfacing things to say, hey, none of us really know what we're doing. But last week I found out that if I treated my AI as a human, it makes my decision making easier, right? That kind of thing I think we need to interpolate and understand and put out. There's a little talk that I did. It was a TEDx talk a few years ago where we were explaining how do you understand the world of medical education in a way that you can apply it to healthcare AI. So before the 1850s, by the way, there was no formal medical education. You learned what you did from, the sundry places. But the first medical school that had a formal education had to understand, how do we formally educate humans to do things over and over again in a scientific manner? We are now in that same, almost like a hazy world where we don't have the first medical schools who are designed to teach AI. So we're all doing it together. We're learning how that goes. I mean, I think 15 years from now, AI will probably go through the same med schools in the same way. It's going to have to interact with us in the same way. Humans will be learning with the AI learns with the humans, all in school. And then you put them, after training, into an inference-based world within a hospital. That to me seems like a reasonable long-term trajectory, because if we treat it like humans, it will interact with us like humans. And then we're working as a team, as opposed to it's a piece of software.
There's some of us of a certain age where we're already envisioning HAL 9000 talking to us and we're treating it like a human and we get a little scared. But that's okay. It's a different topic of a conversation.
That's
I
right.
want to switch gears. I could spend a lot more time on this because I think it's fascinating. And I think the audience also recognizes that we are literally on just the precipice of step one into AI. It's a long journey. So it's interesting that we kind of get this right. I want to stress the ethical component of that, which I think is another fascinating topic. But I am going to switch gears here to kind of that speed round with regard to, I'll give you a sentence or a phrase and you tell me the first thing that pops into your head. You ready?
Yep, let's go for it.
I love your background as it relates to the CIO, the CTO area. So technical skills versus in the trenches skills, which is more important?
So in the modern era, in the trenches, tied with prompting, if we're talking about AI, or adapting existing technology to your current environment. The biggest mistake is treating all technology for all hospitals the same. So the in the trenches tells you, what is my culture and how does my workflow operate? And then how do I adapt known technologies to that local environment? That's the essence of most CIO work today.
Awesome. I like that. We talked a little bit about blind spots and from a healthcare ecosystem as it relates to AI. As it relates to just decision making in digital health, another component of your experience and expertise, and I've talked about it on the program a lot. Digital health is another catchphrase which gets bantered about all the time, and there's no two definitions I think that are similar on what it is. So when it comes to digital health at we'll say hospital, what do you think is the most important two attributes that a hospital CEO needs to focus on, he or she needs to focus on to be successful in digital health?
Yeah, so first would be, what lines of business are going to be able to improve my line of business in a way to either attract more patients, allow the care that I'm giving to my patients to be of higher quality, allow consistency of care across multiple patients. So you notice that a good CIO, a good CEO, a good CFO first thinks about the business that they are in. And we pretend like we say, I'm patient centric. No, you're not. You're an institution. Don't try to fool yourself. You are an institution. You're operating certain lines of business in that institution. And now you have to see, what technologies, of which there are a plethora. There is no need to worry about the invention of new things. Just start applying them to the line of business that you are in, and things then work out a little bit better than if you say, well, if I brought this new technology in, I could be in a new line of business. Right? That doesn't make any sense. As your first order of business is, you know what you're doing, find the tech that hits all of your requirements, such as revenue capture, make sure your margins are set, ensure that patient safety is maintained, all of those kind of things. And that's your first and primary goal. Now, the second and primary goal is to keep your institution in business, right? Mm-hmm. Now, in that particular case, you can start to say, do I acquire my technologies on its own and then build out personnel to use that technology? Or could I just buy a small practice or a small hospital that already is using that technology that I want and then embrace it and build it into my business? So hospitals take a long time to change workflows and people and everything else. Sometimes it's easier to just go buy the thing that you want and incorporate that. And of course, we see this in the regular business world. Right. No big pharma company is in the true R&D business, right? The R&D business is in small companies, small clinical trials, and then pharma companies buy them and then take them through the clinical trial process and then go and build brands. Hospitals have been acquiring other hospitals and clinics, et cetera, but not for anything usually other than accretive revenue or spreading the risk out and those kind of things. So we need to kind of like go back to our business roots and say that the technical part just needs to support the business decision, not the other way around. 25 years ago, pure tech made sense, right? Nobody knew anything, but unlike AI, we know a lot about digital health. We know a lot about how to do integrations, et cetera. So you got to have your business hat on at that time.
I like it. And now I'm going to switch gears on that because we'll just say that's on the clinical side or the health system side. Now let's say on the regulatory side, you are in control of CMS and you have 2 days to enact policy, and none of the policies you enact can be reversed for 5 years. What two things are you putting in place?
So number one, what I would do is to establish the idea that continuous care at home is more important than big box care within a hospital. So almost all regulatory burdens today are placed in a way that says, when the patient comes into the office, here's everything that I do with them. We kind of had this, and CMS has this, a huge blind spot that says everything about healthcare is in an institution. You and I know that that's not true. Everybody knows that that's not true, right. But we haven't established our regulatory framework. So the number one thing I would say is, how can we rethink regulations so that in a, quote, first principles way, assume that digital is in place, AI is in place, and that the care is continuous in nature at home, at the office, et cetera, and that the acute environment that we come into is a one-off that we need to help. Obviously, it has to be regulated as well, but it is a part of the longer-term journey. That would be like, part number one. Part number two is, what could we do to our regulations to move away from being organ-based care to body-based care? So whether that's a functional medicine view of the world, an integrative medicine view of the world. Now, I'm not going to foo-foo medicine. I'm saying there are well-known, well-established clinical trials that have described ways of treating integrative medicine through the body. Like, for example, we've now learned in the past 25 years how the gut and the brain work together, right? We have almost two brains now that have to work in an integrated manner. We know that pure organ-based care works well when we can identify a particular organ is bad, but we don't know how to fix it by itself. Like if you have fatty liver disease, for example, fatty liver disease make you think that the problem is in the liver, but no. The fatty liver is caused by a whole bunch of other things. Correct. It could be diet, exercise, food, et cetera, all kinds of things. And so we are currently assuming that our organ-based care is going to take us into the future, and it certainly won't.
No, I like that distinction. And from a holistic standpoint, I also love the gut biome analysis with regards to we do have two brains, and there's a lot of data out there that says the brain in our stomach is a little bit more important because it's going to influence everything. That's so right. Treat it with nutrient versus some of the stuff we're putting in our stomachs. All right, last question. You are stranded in an airport. and you have a long delay and you're pondering your last 30 years of healthcare, and you're thinking to yourself, boy, I would love to sit down with this individual and talk a little bit and bend their ear. This person can be living or deceased within healthcare. Who are you sitting down with for an extended conversation about all things that you want answers to, and what are you drinking?
Wow, that's a great question. So I would say, one of my favorite healthcare characters, especially throughout history, is Avicenna or Averroes, one of the earliest Arab. He just happened to be an Arab doctor, and he was one of the first that actually embodied this idea that you can't just observe. You got to be able to make a thesis, have a bunch of observations, figure out what's going on. So a lot of what we know about the scientific method, though not formalized in his time, came out of that idea is pure observations alone aren't enough. Pure theory alone isn't enough. And you have to do this observational back and forth. So what I'd be drinking is tea, because I don't drink coffee. It'll be probably Turkish tea. It happens to be my favorite tea. And the conversations would be around what the heck made you think about the fact that it's like everybody else was doing it this way. What made you think about it this way? Especially because obviously in that time, the internet wasn't around, phones weren't around. So you had to do a lot more thinking on your own. You weren't talking to 500 people, simultaneously and getting all these ideas. So that really fascinates me, is how Einstein by himself, or Avicenna by himself, or a Newton by himself, they're just able to, without a whole lot of conversations from everywhere else, come up with these unique, literally world-changing kinds of views. So would love to have that, go back in time and have that conversation.
I love it. And you're right. They didn't have the tens of thousands of inputs with regards to consideration, evaluation, and stuff like that. But yet this idea germinated inside their heads. And how did that happen? And how did they leverage it and pursue it? I love that concept. Shahid, thank you so much. I'm curious, you're the CEO of Netspective. How does our audience, if they're interested in further dialogue, or even kind of exploring some of these ideas formally with you, how do they get a hold of you?
Yeah, so you go to netspective.com. You can also go to shahidshah.com. That has my profile and things that I do. If you want to see those TEDx talks, if you just go to YouTube and say Shahid Shah TEDx, there's 2 TEDx talks that I've done. That one of them is what I talked about at the very top of this conversation, which is how leaders should say yes to things. Like in healthcare, our normal philosophy is, nah, don't need this, etc. So that was pre-AI even, talking about what are good ways to find ways to say yes. And so that was one of them. And the other one is called Medical Science 3.0, which basically explains how do we know that we've reached a nirvana of medical research. And I'd love to come back to your podcast someday and talk more about how we can do medical research and maybe cure something every once in a while.
It would be awesome on both counts, curing and having you back. I really appreciate the time, and certainly you sharing some of your wisdom. There are a ton of lessons that people can use today, especially around AI. So thank you so much for sharing. And for the audience, thank you so much for tuning in. Can't do this without you. Enjoy the rest of your day. And Shahid, we'll be talking very soon.
Thank you so much.